Good day, doctors. I am Carlito Cabo Jr., RTRH OB intern. For this day, I am going to share to all of you a journal report on the association of serum ferritin levels in predicting the outcome in GDM pregnancies. To start this topic, we have a review of maternal physiology. Maternal physiology, there are several changes from a non-pregnant body of a woman to a pregnant one. We have cardiovascular changes, pulmonary and metabolic changes, to name a few. So we have in pulmonary, we take note that there's no change in respiratory rate, lung compliance, and vital capacity. In metabolic change, there's an increase in metabolic rate, especially in the third trimester. So there's weight gain of 12.5 kilograms approximately. There are also changes in carbohydrate and fat metabolism. For carbohydrate, we have mild fasting hypoglycemia, postprandial hyperglycemia, and hyperinsulinemia. For the fats, there is hyperlipidemia in pregnancy, and in the third trimester, these fat stores are actually decreasing or decreases. You also have hematologic and immunologic changes. For hematologic changes, we have hypervolemia and also increased reticulocyte count. There's also higher demand for iron or iron metabolism. So the iron requirements increases to 1,000 milligrams. Immunologic changes. So early pregnancy is considered pro-inflammatory. The mid-pregnancy anti-inflammatory and parturition as recrudescence. Now I have here a table showing the association or relationship of total iron binding capacity, the serum ferritin level, and the iron saturation. So in pregnancy, there is a fall in the serum iron and percentage saturation of the total iron binding capacity. The fall in serum iron can be largely prevented by iron supplements. Serum iron, even in combination with total iron binding capacity, is not a reliable indication of iron stores because it fluctuates. I'm sorry about that. It fluctuates so widely and is affected by recent ingestion of iron or factors such as infection, which is not directly involved with iron metabolism. Now, with these major reservations, a serum iron of less than 12 millimoles per liter and total iron binding capacity of less than 15% is the one we use as indication of iron deficiency in pregnancy. Now, the image on the right side is just to show you that the fasting glucose, there are studies showing that the fasting glucose of pregnant women uh, are actually much lower than the standard we have for the normal fasting blood glucose set by the ACOG. Now going to the report, so the journal I am going to share to you is from the International Journal of Clinical Obstetrics and Gynecology. It's entitled The Association of Serum Ferritin Levels in Predicting the Outcome in GDM Pregnancies. So this is a study conducted by Sharon Deepti Raskinha, Victor Raskinha, and Sankit Dumal. So this study was done in um, India. So this was done in India, K.S. Hegel Medical College in India. For the introductions, so gestational diabetes mellitus is one of the most common pregnancy-related complications. The incidence has a rising trend, especially in India and their place, and approximately 14% of all pregnancies develop gestational diabetes mellitus. The disorder that occurs as a result of impaired tolerance to the carbohydrate metabolism. As mentioned earlier in maternal physiology, there are changes in carbohydrate metabolism in pregnancy. So it has its onset most often after the 24th week of gestation, and the disease tends to subside following childbirth. It coincides with the period of maximum growth of the fetus during the period of gestation, and it is used to explain the development of gestational diabetes mellitus, that is of oxidative stress and systemic inflammation associated with obesity. Now, among the factors responsible for the generation of free radicals and cause inflammation is found to be the presence of abnormally high amount of elemental iron. So as we all know, serum ferritin is actually an acute phase reactant. So there's in some of the studies, so there are evidence that by estimation of serum ferritin levels in patients with gestational diabetes mellitus, it is possible to predict the obstetric outcome to a fairly correct extent. Hence, this study evaluated the association of serum ferritin measured in mid-pregnancy to predict the risk of developing gestational diabetes and maternal and neonatal morbidity. So that's the purpose of this study. Now for the methodology of the study type is case control. The setting is the K.S. Hedge College Hospital in India, and the date of studies span from December 2016 to July in 2020. And the sampling method was convenience sampling. Now for the participants' inclusion criteria, um, so the one that the one that was included in the study was antenatal patients aging from 20 to 40 and with a gestational age or the age of gestation of 12 weeks to 40 weeks and diagnosed with GDM by the American College of Obstetricians and Gynecologists in their present pregnancy during the antenatal checkup. So I have here a table of ACOG that's the recommendation for diagnosing GDM. So these are the normal values. So yes, so I can see. Now for the control group, these are the uncomplicated normoglycemic antenatal women with age of gestation 12 weeks to 40 weeks and were randomly chosen. Exclusion criteria. So those are the patients that known patients of type 1 or type 2 diabetes mellitus and with other systemic diseases to prevent variables in the study. The data collection, detailed history was taken from the patient who visited for regular antenatal checkup and was screened. Participants of the study were included as defined by the inclusion and the exclusion criteria, and the gestational age was calculated by the date of last menstrual period and confirmed by the ultrasound scan in early pregnancy. The serum ferritin levels were collected between the 24th and 28th weeks of AOG. For the data processing, the data collected was analyzed by SPSS version 23, and comparison of ferritin levels with the study population was done with the control group. Ferritin and glucose challenge test values were correlated. So for this study, they took the ferritin levels at 24 to 28 weeks AOG and also the glucose challenge testing. So these are the two variables they actually used. For the results of their study, the study population was matched with that of controls with respect to parity, age, and period of gestation. The total number of participants they had was 248. They had equal number for the GDM patients and the control group, the non-GDM. The mean age of participants, so these are the profiling, it's 24.12 for the GDM and 25.31 for the non-GDM. So the lesser gap in the change between the participants. And the primigravid, the participants, we have 69% from the GDM group and 71% for the non-GDM group. The mean gestational age of the study population for the GDM is 25.85 and 26.23 for the non-GDM. So there's lesser difference. Now we had the values here for the result. The mean serum ferritin level is taken in the GDM group is 79 with a standard deviation of plus or minus 15.63 nanograms per ml. And for the non-GDM, it's very low. That's 30.8 nanograms per ml with a standard deviation of 6.02. So we have here a table showing the results And also the p-value used was 0.0001 with a 95% confidence interval. So this is actually a standard we use for this type of researches. Here, so they actually tabulated um, here the association. Now, the relationship of elevated range of glucose challenge test value and the mean ferritin values. So it's there's a lot of numbers here. So they shown a table or a scatter plot, a diagram, a scatter plot of the linear regression. So their correlation coefficient using the samples from this table. So they have a 0.614 correlation coefficient. Now, for correlation coefficient, 0 would represent it's a value from -1 to +1. So the higher the number, the higher the association is. So 1 would mean a perfect association or a very high association. Now we have a value of 0.614. So this means that the interpretation is that it is weakly positive. So there's weak positive association between the glucose challenge test and the mean ferritin levels in their studies. You also have the regression line equation here, showing now that there are actually other or the trueness of the association in the regression line or the best of fit line. So that's their result. Now going to the discussion. For pregnancy and diabetes, a unique situation in which there is a requirement of feeding two people. There exists a physiological equilibrium such that adequate nutrition is provided to both the mother and the developing fetus. Progressive increase in the insulin resistance and hence pregnancy is considered as diabetogenic state. And in India, the incidence of GDM can be as high as 40 to 60%. So as previous data, they said that it is up to 12%. But in their place in India, it can be as high as 40 to 60%. And some studies are actually saying that this will keep on rising, and this is attributed to the increase in the increase and reflection of the increasing obesity and metabolic syndrome among women, especially in their population. Gestational diabetes mellitus. So it's any degree of glucose intolerance with onset or first recognition during pregnancy. That's by definition of WHO and ACOG. And it includes women whose glucose tolerance returns back to normal after pregnancy, and those who will develop type 2 diabetes with persistent glucose intolerance. Now, for the criteria of diagnosing GDM, we have here, it's fasting glucose of more than 126 milligrams per DL, postprandial of more than 200 milligrams per DL, and random blood sugar of more than 126 milligrams per DL. We also have another definition for overt DM. That's more than 126. And now we have the challenge test, which is with the result of more than or equal to 200 milligrams. Yeah, so it's still the now for ano naman dito, for the diagnosing of GDM, so this is taken from Williams. So we use naman the more than or equal to 92 milligrams per DL fasting blood sugar. And the glucose challenge test, we use 75 grams oral glucose OGTT. So if we have a more than or equal to 180 milligrams per DL in 1 hour, and in 2 hours naman we have 153 and still 140 at 2 hours, then we can consider it as GDM by this criteria. Now, the factors responsible for insulin diabetogenic state, we have increase in the insulin resistance, increase in the lipolysis, and increase in gluconeogenesis, which were all found in physiologic changes in maternal physiology from non-pregnant to a pregnant body. Progesterone and estrogen. So they may act directly or indirectly to mediate insulin insensitivity. Placental lactogen also plays a role, so it may increase lipolysis and liberation of free fatty acid, which increases free fatty acid and leading to tissue resistance to insulin. They also enhance destruction of hormone insulin by the maternal kidney and the placenta, which secretes insulinase. So with all of this, it will lead to insulin resistance and impaired or glucose intolerance. The increase in ferritin levels appears to be independent of hemoglobin status, and high ferritin levels observed in GDM group could be positively associated with higher BMI values. And this could explain that serum ferritin as an inflammatory marker was found higher in GDM mothers due to maternal fat and obesity factor. So about this, it's not well explained. So in obese pregnant women, the upper body fat deposits are predominant, and the predilection for storing fat centrally increases the concentration of free fatty acids and lipotoxicity that leads to inflammation, endothelial dysfunction, and decrease in trophoblastic invasion, and consequently a reduction in placental metabolism and function. And some studies also states that the serum ferritin, in association with um, obesity or higher BMI, would relate to the pro-inflammatory effect of obesity as being ferritin as an acute phase reactant. However, there are other studies with conflicting take on this, and they said that it needs further studies. So, in this study, they also shared the other references. So they have several studies cited showing that there's actually a correlation between serum ferritin and the GDM or the developing GDM, and even prognosticating or prognosticating GDM in some studies. So we have here a study showing that in his prospective study in pregnant women in early gestation, they found out that women who developed GDM had a higher concentration of serum ferritin than women who did not develop GDM. So it was actually coincide with their study in this paper and several others. Now, for their conclusion, the researchers concluded that GDM is likely to be associated with high serum ferritin levels compared to the non-GDM mothers. And by evaluation of serum ferritin levels, it is possible to predict the outcome of mother and the newborn. So, um, for the recommendation, there's none. Now, for my take on this journal, so for journal appraisal, um, so for the title, it is concise but slightly confusing. So it was not specific. So what effect to what outcome are we specifically taking the study to? So the abstract was structured and summarized in study. Introduction For the introduction, the rationale of the study was clearly stated and the objective was clearly stated. For the methodology, so my take is that they did not have any ethical. So the consent was not. There was no data or there were no statement about the consent of this study. So we are talking about a study of pregnant women. So there's um, bound to be ethical issues, but there was no mention in the paper. So for the result, the answers they did answer the objective and was consistent all throughout. However, the illustrations or tables in the study was actually very. It was not easy to read immediately. So for the discussion, did the answer the objective? Yes. Did you discuss the strength and weakness of the study? So actually no. And for the implications and applicability, they did not mention any of that. For the also, I would just like to add that in their conclusion they used likely to be associated and possible to predict the outcome of the mother. So possible to predict. Now the result of the of the coef- uh, correlation coefficient is actually 0.6 is weakly positive. So it might not actually totally true to all cases. So I think um, for my part, um, uh, they should further studies should be done to truly assess the relationship of the serum ferritin and the GDM, because the result um, there's definitely an association between serum ferritin. However, it's not strong enough to prove the true relationship between serum ferritin and GDM outcomes. So the conclusion of the appraisal is not well-constructed research paper. It's highly likely that this journal is not well peer-reviewed and provides background information on the association of serum ferritin levels and the development of GDM in pregnancy. So it needs a standardized definition of terms. Yes, and also it's good to have to know that there are researchers or there are research trying to find association um, with the current knowledge now to that might be used in future practice. So that would be all for my report on the journal report on the association of serum ferritin levels with the outcome of GDM pregnancies. Thank you, everybody, and have a good day.